Hello, everyone, and welcome to APHA's Addressing the COVID-19 Crisis, our weekly open forum webinar series for pharmacists. We're glad that you're here with us today. I'm Michael Hogue, the Dean of Loma Linda University School of Pharmacy, and I'm the 165th President of APHA. It's our pleasure to have you here today as we discuss some pretty exciting topics in telehealth. So we'll talk about that in just a minute. We're going to jump in. We're really going to cover a gamut of perspectives in telehealth today, which I think you'll find quite exciting. There are so many nuances and aspects of telehealth, and it's become, during COVID-19, such an important part of our healthcare system. And knowing how pharmacists integrate into telehealth and how we use telehealth to reach at-need populations, really important topic. So I think you'll be very excited to see and hear what we're going to talk about today. Now, let me just take a minute and introduce to you our guests that we have. We have 3 guest speakers today, and then we have 3 of our staff members that are joining us today as well. So our guest that we have today, first of all, is Nikki Scovis. Dr. Scovis is a graduate from the University of Florida, and she completed pharmacy residency training at the North Florida, South Georgia Veterans Healthcare System in ambulatory care, and then became board certified as both a pharmacotherapy specialist and as an ambulatory care pharmacist. She is the Director of Strategic Growth with Tabula Rasa Healthcare, which is a company that has a what I would call an employer-based model or health plan model, telephonic MTM and telehealth service. So she's going to give a perspective on that. We're also joined by Kathy Doan. Dr. Doan is a clinical pharmacist at the Caring Health Center. She received her BS in nutrition and dietetics from the University of Puerto Rico and did dietetics internship in the Department of Health in Puerto Rico. And then she got her PharmD from the MCPHS University in Worcester, Massachusetts. So great background. She actually is working currently in a federally qualified health center and is utilizing grant funding and other mechanisms to support pharmacists' involvement in direct patient care and now through telehealth. So again, a second or different perspective than our first speaker. And then our third speaker is Dr. Taylor Myers. Dr. Myers is a graduate of South Carolina College of Pharmacy in Columbia. She did her postgraduate training in the community pharmacy setting at University of South Carolina and Medicine Mart Pharmacies. Now, Taylor has an even third and different perspective in that she is a what I would call a traditional ambulatory care pharmacist embedded in an ambulatory care clinic with a group of physicians and using traditional models of care in the outpatient setting in ambulatory care. And they have, during the COVID crisis, also been using telehealth, and so she's going to share those perspectives. Now, in addition to our 3 guests, we are delighted once again this week to have with us 3 of our staff experts. First of all, Mitch Rotholtz, who's the Chief Strategy Officer at APHA. And Mitch also, as most of you on the call are aware, is really the immunization guru on APHA staff with lots of connectivity with vaccines and so forth. He'll be joining us a little later on to share some news that has happened since our last broadcast related to adult and adolescent immunization services, well, really the whole lifespan of immunization services. We're also joined by Dr. Dan Zlot. Dr. Zlot is our Vice President for Professional Education, and he'll be answering your questions as it relates to clinical topics, whether they be drug therapy or other clinical issues that you may have questions about related to COVID-19. and then Dr. Lisa Bernstein. And Dr. Bernstein is Senior Vice President of Pharmacy Practice and Government Affairs at APHA, and as all of you who have been with us regularly know, Elisa comes to us after a 30-year career in the FDA, and so she'll talk about regulatory issues that may come up or questions that you may have about that, and she will be sharing some information with us later in the program as well. So we've got a lot of things to cover. It's a program that's just chock full of information, and I know you'll have questions. So let me just give you a couple of little highlights of things that we need to do. In the GoToWebinar control panel, you will see that there is an opportunity there for you to enter questions. We would like to encourage you to go ahead and ask your questions in writing in that box, in the questions box, as soon as you think of those questions so that we can get you in the queue. What we would like to be able to do is when we get to the appropriate point in the program is if you have audio enabled on your telephone or on your computer, we would like to call on you to ask your question verbally. Now, if you don't have audio capability, you can just put in your question no audio, and then that'll give me the signal that I just need to ask the question on your behalf. So either way, that works. If you're on a handset phone, be sure to enter your audio PIN number now so that your handset will be active, and when the APHA staff unmute your line, you'll be able to speak. But we do want to encourage you to just, as you think of questions, go ahead and ask those questions so that we can get them in the queue and work on those questions. Just a reminder, today's program is being recorded and will be available within 24 hours at pharmacists.com in the COVID Resources section, and you can access that at any time. We will also and do have available for you in the handouts tab in the control panel the opportunity for you to see and download a copy of today's handout, and we'll have information in there later in the program that you may want to have access to after the program. So we just call your attention to that as well. So that's all of the housekeeping announcements I have. I'm going to ask our guests, Nikki, Kathy, and Taylor, to activate their webcams and to join me here live on the program. Nikki, welcome to you. Taylor, welcome to you. And Kathy, welcome to you. We're glad to have you each here today. Thank you for joining us. Well, I think the best way for us to start out is just to let each one of you take a moment to provide a brief description of your practice setting, sort of how you work with other healthcare providers, and what's going on relative to telehealth in your work. So we'll start with Nikki. Nikki, tell us a little bit about your practice.
Thank you for having me, Michael. So within Tabula Rasa Healthcare, our primary practice is in telehealth. So we've been doing telehealth for over a decade with respect to MTM, like you mentioned in the intro, as well as medication safety and hospital discharge programs. We've also recently launched a diabetes prevention program via telehealth, but we also have programs that we're being provided face-to-face within our community pharmacy network and within clinical practices that have transitioned to a telehealth model in the wake of COVID-19. So we're seeing some of that transition, even though the primary business that we do is rooted in telehealth.
That's great. Thank you so much. Taylor, how about telling us a bit about your practice?
Absolutely, thank you. My name is Taylor and I work at Prisma Health. I work in 3 different primary care physicians' offices. So I bounce between them and also work through the EMR mainly to help the providers with questions dealing with medication management. Prior to COVID, I'd say I saw about 50% of my patients in person, and the other 50% was already doing chronic care management through telehealth. Since COVID, it's all been telehealth. So switching over to lots of chronic care management over the phone or through video, and trying to help the providers with shared visits through telehealth as well.
All right, great. And Kathy, tell us about your practice.
Hello, everyone. Very happy to be here and share my experience with you all. I currently practice the Care Health Center that you mentioned in the earlier introduction. It's a federal qualified health center. It's actually located in downtown Springfield. Prior COVID-19, we didn't have too much training in telehealth. Since this pandemic started, we actually transitioned from 0 telehealth visits to be fully operational in only 2 weeks. So right now we are only just seeing telehealth appointments from not training before. We implemented a couple things through the telehealth. We integrated an automatic phone system that calls the patients and confirms appointments. We also trying to educate patients on how to use MyChart, which is a portal, online portal where the patients make appointments and contact the providers through MyChart. And also we are working to do group sections by computer. That's something that we're working on it just to continue providing our services. And this is just been trying to do telehealth visits in only 3 months. We didn't have this before.
Wow. You know, Kathy, you just raised an issue that I think is so amazing. I think all of us, our minds are just expanded at how quickly the entire health system turned on a dime. It was headed this way and turned on a dime and then was headed this way. It really is amazing. It's just amazing. And what the three of you have done relative to this in telehealth, I mean, really, you're innovators, and I appreciate that. I think it'd be good for our audience, perhaps, to just consider some of the basic things that need to be taken into account when we approach telehealth. And I think we've got a slide we're going to put up as some of the considerations for pharmacists. And as this slide is up, Nikki, I wonder if you might be willing to share with us just some of the general requirements for telehealth services and some of the changes that you've seen happen with existing telehealth services based on the COVID regulations. So maybe you can give us a little bit of a foundation to start with.
Yeah, absolutely. So there's definitely a pre and post situation here with respect to what telehealth looked like before COVID and what it looks like now. So before COVID, there were really a lot of restrictions on who was eligible to receive telehealth. So it was restricted primarily to patients in rural areas where there weren't providers that were available to care for them in person. There were also some restrictions on where the patients could be and where the providers could be. So the location, the physical locations of the patients and the providers. And then there were also some restrictions on how telehealth could be delivered. So namely that audio and visual components were required. With the advent of COVID-19, what we've seen is an easing of really all three of those things. So who's eligible under Medicare? Now all patients have access to telehealth. Under commercial and Medicaid plans, that may vary a little bit, but a lot of them have also followed suit. The provider and patient locations are no longer restricted. So the idea is that in this situation, we need to make sure that patients have access to care. And however we can do that, we need to make sure that that's happening. And so if the patient, you know, can't get into the clinic, or maybe we don't want them to be going into the clinic because they're at high risk for contracting COVID, then we want to make sure that we're addressing those issues. And then lastly, technology. So there's been an easing on the technology that can be employed with telehealth. So for patients who don't have access to technology, you know, Kathy mentioned that they're using the MyChart. And so technology is sometimes a real issue for patients to be able to access care. And so again, CMS wanted to make sure that that was not a barrier for people to be able to access care. So they're allowing more consumer-facing apps for the delivery of telehealth rather than just platforms that are HIPAA compliant in order to increase access for patients, as well as decrease patient risk by having in-person visits, especially in those at-risk populations.
Yeah. Well, that's great. And Kathy, I wonder if you could tell us, what has really changed? How has your practice setting changed since COVID? I mean, in terms of the telehealth services, were you doing telehealth in your practice prior to COVID, or is this something that's new for you?
Prior COVID, we had some trainings before how to use the system in case that we're going to do some services through the computer. But prior COVID, we didn't have any telehealth services implemented at all. Right now, in terms of my practice, how it looks like, we actually primarily do telehealth visits for most patients. We have 3 sites. There's 2 sites that are closed at the moment. We only have the main site open in case there's somebody, a patient of us, have an emergency and needs to see the provider, because in an urgent matter. But we try to limit the patient visits at the clinic. So we mostly just trying to do fully telehealth appointments right now, visits, in case that something needs to be done, like blood work or labs. We are actually just limited those visits at the clinic. We have some staff that actually are outside the clinic, making sure we ask a couple questions to the patients that are coming into the clinic in case they were traveling outside the country, either sick or any symptoms. We are measuring temperature, making sure that in case that the patients get inside the clinic, they're safe and not sick, or there's no any exposure. But pretty much we are trying to limit the contact and limit the patient to be in the clinic just to prevent any possible contamination or at the clinic.
Okay, and Taylor, same question for you. What's changed? What were you doing before, and what's changed with COVID?
Very similar to Kathy. Before COVID, we weren't doing telehealth at all in the traditional sense. But in the heat of COVID, we switched all of our visits to telehealth. We weren't seeing anyone in the practice unless it was an emergency. We were doing a lot of triage for those emergency patients who really felt that they needed to come in and see a provider. So we had designated personnel to call them and ask them a series of questions to determine if it was safe for them to come into the clinic. We've been using Vido to try to do these telehealth visits, which is one of those HIPAA compliant platforms. And recently, we started seeing more patients in the office. We're bringing in probably about 30 to 40% of our patients that we're seeing now are in person, and the rest are telehealth. But we're only bringing in 1 patient at a time. We're having them wait in the car until we call them to come in, and then doing the temperature and the masking as well.
All right, now I'm going to ask the question that if I had to guess the biggest question on our audience's mind, it's how do you get paid for this? How does a practice, and I'm not talking about how an individual pharmacist necessarily gets paid, because we're employed by the practice, and so it's the practice that would do the billing. Is there compensation associated with the services that you're providing? I think in the conversations I've had with the 3 of you previously, you all have a little bit different approach to the compensation question. And I'm not asking you to reveal dollars and cents. I'm simply wanting you to talk about process. So Nikki, I think maybe you could start us off here.
Sure. So this is a complicated topic, I feel like. Really, there are barriers to payment because of lack of provider status, and that persists within the current environment. So opportunities for payment are similar. We have incident to billing that we can do, and so what that means is the physician can bill for our visits as part of their overall care plan. So that's one method. Supervision via telehealth is a little bit complicated. The supervision for incident to visits is generally direct supervision, which means the provider has to be in the same suite of services under normal circumstances. Via telehealth, that means they have to be available via audio and video components, but even that's been, enforcement's been relaxed a little bit. And then there are more traditional telehealth billing codes like chronic care management and transitional care management that might also be opportunities.
Okay, Taylor, tell us about how it's a little different in your setting.
Sure, it's actually pretty similar as far as chronic care management goes, but the majority of what I've been doing is a lot of shared visits with the providers. So I might do a portion of the visit, but the provider's doing the bulk or the meat and potatoes of the visit. And then because of some of the restrictions that have been lifted on billing through telehealth, they've been able to see patients and bill for visits like they normally would.
Yeah, so what you're describing actually is that the providers are billing for the total care services that are provided. They might be billing at a higher complexity code because they've got you involved, and the time that it takes for the visit might be longer because they've got you providing some care and they are providing some care. Is that a fair statement to make, or is that how it's working basically in your practice?
Absolutely, you nailed it.
All right, great. Kathy, tell us about the federally qualified health center model. I mean, how is your position sort of supported within the FQHC? Is it something that you're doing direct billing for? I'm guessing that you're not, but I'm not positive about that. So tell us about that.
Michael, it's actually a mix. Primary support in terms of my salary and my role at the clinic through different grants, and we have applied in overall. But I also do some share appointments with providers where they do exactly the same as Taylor, that they bill for the appointments for the share visits. And in some circumstances that I see patients myself, I do the billing code 99211 in case that I do just a quick revision of the meds, or if I have to do some medication changes myself. I have a collaborative practice agreement with the facility, with the medical officer at the health center, so I do some medications adjustments as needed. So I could also do the billing myself, but the billing code that I can only use is the 99211.
Okay, great. Well, that's very, very informative on all three parts. And I think you all have kind of covered the types of clinical services that you're doing. So Taylor, I think I heard you say that chronic care management services under Medicare is one of the things that you're doing. Is that right? Are there other specific services for your patient population?
Outside of chronic care management, we're doing annual wellness visits. That's the other big piece that I've started doing. I was helping with those a lot in person before COVID, and now during it, I've been helping out with those still, but through telehealth instead. But those are the two specific things. Everything else is access to care related.
Okay. And Nikki, you kind of described that MTM is your bread and butter, if I can use that terminology, and that maybe there's some other services that most recently, because of COVID, that you've been providing. Can you expound on that piece of it just a little bit?
Sure. So within our community pharmacy network, a lot of the pharmacies are providing things like MTM in person, adherence counseling in person, even things like diabetes management. But in the wake of COVID, a lot of those services have switched then to telehealth modalities. Similarly, we have pharmacists embedded in more traditional care settings, and those focus mainly around disease state management under collaborative practice. And just like Kathy was describing, that those have also switched to telehealth.
Okay, that's great. Well, that helps with understanding. Now, I want to talk about the time issue. Okay, we all have a mindset about how much time it takes to see a patient in the face-to-face environment. You know, what's your take or observation on the amount of time you are spending with patients on a telehealth visit? I'm absolutely certain that it varies depending upon the type of service that you're providing. So I'm sure that that's the case. But Kathy, for the services that you described to us, you know, what's your average visit look like in terms of time?
It could take me between, I would say, 15 minutes to sometimes 45 minutes in some patients. We have a big population with different languages. So we have over 20 languages spoken within our community. So sometimes we have to use interpreters and other staff to the telehealth. So once we have some patients that doesn't speak our language, we have to use other staff. So it takes time to communicate with the staff and then to reach the patient. And if we lose connection, so we have to call them back, and it could take a little time.
Yeah. Taylor, what about you? I'm guessing that those annual wellness visits take a while. What's that look like?
Yeah, they do. So they've actually taken less time than in person, but still are taking anywhere from normally about 25 to 45 minutes to complete an annual wellness visit. The other visits have either been way shorter than in person or way longer, just depending on how the person does with technology. So it's been a wide range.
So technology on the patient side can be a little bit challenging depending on abilities there. So a lot of people have had to switch very closely. And Nikki, what have you seen as the biggest challenges that patients have had in adapting to you providing care via telehealth? Have you seen changes?
Yes, so I think I would echo what Taylor said in terms of any extension of the visit length is really due to helping them solve technology issues and making sure that we can connect effectively.
Yeah. You know, Taylor and Kathy, for the two of you, you're working in clinics alongside physicians and nurse practitioners and PAs, I'm sure, specifically. You know, have there been any aha moments with those providers? Have they understood or recognized during the COVID crisis that there are some gaps in care that you're uniquely qualified to fill? Have you seen some of that new recognition of, wow, we've got a pharmacist here and we need to have this pharmacist doing this service? Taylor, why don't you start us off?
Sure. I think one of the big ones has been medication understanding. Of course, you know, when they're in the office, I think it's a little easier for the providers to explain that, but when they're trying to do this via telehealth, sometimes things might not come across exactly the way that they want them to. So on follow-up with that, I've been utilized a lot more because there's been a lot more errors since telehealth has been utilized. And then also access to care. So I was already doing access to care before, but now it's so much more heightened because of folks losing their jobs or just having trouble driving places. And I know a lot of those resources to help them out. So it's been a big aha moment there that there's other things out there to help those patients that pharmacists are a good person to help with.
Yeah, Kathy, what about you? Have your physicians and other providers had some aha moments?
They actually they have been. They actually know that having a pharmacist in the team is very important, just because when they have questions about medications or have drug interactions, or they wanted to get more insight from our perspective, so they have me inside and they have me close by that they can stop by and talk to me. Right now that we're doing telehealth, that we're not all together, so now we have to use text messages or phone calls or in baskets messages to connect. But yes, there have been some.
Yeah, you know, Nikki, you're dealing with large populations and doing some population medicine in addition to the individual patient interaction. And I'm curious to know, I think Taylor brought up this idea that, sometimes there are more errors that happen when we're working remotely and electronically. Are there some things that you've picked up on from a population standpoint that pharmacists that are listening to today's program might want to watch out for in terms of errors in prescribing and so forth? Have you seen any patterns over this time that we've been in the COVID world?
So I haven't seen any particular patterns and errors in prescribing, but what I have seen is that since the onset of COVID, a lot of clinics have really not done a lot of non-urgent care for their patients. And so some of the things that would ordinarily be caught in a visit aren't being caught except through some of these telehealth outreach programs by pharmacists, that like adverse events and medication duplications and things like that might be caught in an in-person visit, but because they're not seeing their providers, the providers in a lot of clinics are just not seeing patients except for urgent visits, and so they're sort of falling through the cracks.
Yeah, I heard a story from a pharmacist recently, a community pharmacist who had received a prescription for an antibiotic that was written by, it was actually handwritten by an emergency department physician. And this emergency department apparently normally has pharmacists routinely engaged, but because of the limiting of traffic, they've limited where pharmacists are involved and where they're not. Anyway, long story short, the community pharmacist discovered that the antibiotic dose was terribly subtherapeutic, that it was not a therapeutic dose of the antibiotic. And so I guess I think that maybe community pharmacists might want to be alert that this time frame with telehealth and the move away from some things is actually creating some problems in prescribing that we need to be alert to. So I wonder, we're going to start taking audience questions now. If you have a question, let me just ask the audience, please type your question into the question box. We'll be happy to direct that to our three guest speakers today. And we're also happy to take your questions on clinical topics as well as government and regulatory topics. To kick us off, I'm going to ask a question of a person whose line is muted. What tips could you provide to keep the patient engaged and with you during their time that they're on the visit? How do you keep patients engaged for 25 or 30 or 45 minutes in the conversation? Do you have any tips on how you do that? Taylor, you want to start us off?
Sure. I try to ask them as many questions as I can. Just keep them talking. I think when you start talking and don't break and give them a chance to ask questions, that's when they tend to disengage. So just keep asking them questions, check in, see if they have questions. Can you repeat that back to me? All the things that we learned in pharmacy school are helpful.
Okay, that's great. Yep, keep them talking. Kathy, do you agree with that? Any other tips you've got?
Yeah, I'm with Taylor as well. So I have like a screening questions that I go through, and I'm trying to make sure they are communicating with me through the entire visit.
All right. And Nikki, any other suggestions you have?
Yeah, so one of my tricks is to really identify very early on what their chief complaint or chief concern is, and then sort of weave that through the conversation.
All right, that's great. Yeah, we've got to keep patients involved in their care. That's for sure. That's an important thing to do. I'm going to ask our staff to unmute the line of Caitlin Johnson. Caitlin Johnson, we want to receive your question.
Okay, awesome. My question was, we're currently working on at-home testing for COVID-19 with both pharmacists and nurse practitioners as part of a large community pharmacy chain. Do you have any advice with designing or setting that up for pharmacists and establishing telehealth services, as we don't currently have it established already?
Great question. Great question. Any of our speakers want to address that one? What are your thoughts on that? Have any of you been involved with COVID-19 testing and remote counseling about that? Nikki's shaking her head yes. Maybe you want to take a stab at this one.
Sure. So what we have done is sort of on the back end of that, where we're doing some remote patient monitoring, which is another billing opportunity that we didn't talk about when we talked about billing, to be able to monitor patients for COVID symptoms, and then using that information to be able to identify who the best candidates are for testing.
Nikki, are there codes specifically for COVID-19 patient monitoring? You mentioned that as a new billing opportunity, or do you use codes that are already in existence, CPT codes?
Those are the existing remote patient monitoring codes.
Okay, all right, great. Well, thank you for that. That's good. We have a question that I think probably would be best aimed at Kathy, given your background in nutrition, also in addition to pharmacy. Diana Khaled, we're going to unmute your line. Diana Khaled, K-H-A-L-E-D. Okay, I'll ask her question. Tell us about nutrition in COVID-19. Kathy, can you tell us anything about your observations with patient nutrition in COVID-19? There's so much about nutrition that interweaves with drug therapy and effectiveness of drug therapy. So talk to us about that just a bit.
Yeah, my primary role at the health center is diabetes management. And when I talk to my patients about diabetes management, of course, we address the nutrition and eating habits. Since COVID-19, I have seen that many of my patients, the eating habit has changed. Just because they are more at the house, they're more anxious, they're eating a little bit more than before, more frequent snacks, bigger portions. They also are unable to exercise. So the lifestyle has changed a lot since COVID-19. I have seen that patients have a lot of questions in terms of what they should eat, what are the portion sizes, and they're very, very anxious, making them just to overeat before the usual eating pattern had changed because of this. So I try to cover a little bit about nutrition also in every patient as possible. But yes, this COVID-19 and this pandemic has impacted a lot in the patient's lifestyle. Absolutely.
All right. Well, thank you for that insight. We're going to unmute the line of Alicia Chin. Alicia Chin.
Hi there. Can you hear me?
Yes, we can hear you.
Okay,
Thank you.
so my question is, how do you better manage the calls for those of us who are not as used to doing telehealth? Because there's the whole introduction, talking to patients, closing off a call, because we do have other people scheduled too.
That's a great question, Alicia. We could probably do an entire webinar just on that one question. But I wonder, Nikki, could you give us some tips from your perspective?
Yeah, so I think that's an age-old question of being able to control the conversation, and particularly via telehealth. So I think setting clear expectations for the visit, of the flow of the visit, is really important in being able to do that. But even then, it can be really difficult. And I think particularly during this pandemic, a lot of people are feeling lonely and isolated. And so I think that I would add that this is an opportunity also to identify people who are having additional struggles with that isolation, to be able to refer them out.
Taylor, any additional suggestions?
I completely agree with Nikki. When I tend to jump on the call, I always tell them, hey, this is Taylor calling from Dr. So-and-so's office. I have that you have an appointment today from 2:20 until 2:40 is now a good time to complete that appointment. Just so I sort of throw that time in there. But yeah, everything Nikki said, absolutely.
Do you have a favorite closing line? Is there a favorite closer?
I really don't. That's something I'm still working on. That's one of my hard things, is getting off the phone. So.
Off the phone, yeah. I imagine that's quite a challenge. Kathy's shaking her head yes too. That's a challenge for you as well, I take it.
They are, I mean, they want to talk to you, like Nikki said too. So they're isolated. They're probably not talking too much with their family members or going out just because they're afraid because of the pandemic. So, and then you call them, you call them to see how they're doing and just do the assessment, but also they wanted to talk to you about their day, what they're doing, stuff like that. So it's hard to actually finish the phone call sometimes.
Yeah, yeah. Well, we've got a question here that I was going to ask earlier, but I'm going to let our guest, who's our audience participant, ask this question. Gina Santorelli has a question about state regs related to this, and I may also ask Elisa Bernstein may want to chime in on this question since it's a regulatory question. Well, we're not hearing Gina. Gina, I'll do my best to try to ask your question. There are state rules and regulations around telehealth also. So it's not just CMS from a regulatory standpoint. I mean, we've talked about CMS and the billing regulations that exist on telehealth in terms of what you can do and when you can do it and what's billable maybe from an insurance perspective. But there are telehealth laws and regulations at the state level, and some states have not yet given pharmacist provider status. So first of all, I'd like to see if any of our guests would like to speak about that, and then I'm also going to ask Elisa Bernstein if she has any insights or thoughts about that topic. Nikki, I know you work on a national level. What's your insight in terms of across the states?
So different states have different regulations on pharmacy practice across state lines in the first place, and so those rules generally apply to telehealth as well. One of my favorite resources, and I know we're going to provide some resources later in the slide set, is the Center for Connected Health Policy, where you can actually sort by your state. So that's one of the resources I like to look at.
Okay. Elisa, would you like to elaborate anything from the federal perspective in terms of what pharmacists need to think about or look at in state regulations?
Yeah, I thought Nikki gave a really good answer, you know, and it's very state dependent. So you really need to look at what the state rules requirements are. You know, under NABP has a passport program, which allows in certain states you can be, it facilitates you to be licensed temporarily in another state, but you still have to abide by the rules and regulations in that state. And if you're required to have some certain amount of training or credentialing or something, you still will need to abide by that. So read and look and read closely, ask questions just to make sure that you're complying appropriately with the rules and regulations.
Yeah, that's great. And I would just point out to all of our listeners that your state pharmacy associations can be a tremendous resource to you. I would encourage you, if you're not already a member of your state pharmacy association, to join and to turn to them to help you with understanding the telehealth rules and regulations in your state. I think that's very important as well.
Michael, could I just add?
Oh, yes.
Michael, I want to add, NASPA has some really good information on their website as well, and you may want to go to that website too.
That's great. And related to resources, we've put up on the slide here a grouping of web links that you can access. We've collected them all here in one location so that hopefully for convenience, you'll be able to find some information that will help you if you're looking to get into telehealth services. We're going to take a couple more questions, but before we do, I want to do a polling question this week. We want to kind of gauge where everyone is in our audience relative to thinking about providing telehealth. I'm sure some of you are doing it already and some of you probably aren't. So we'll put up the polling question: which of the following best describes your involvement in telehealth services? You're not providing it and you don't have any plans to do so. You're not providing it, but you're interested in starting to provide it. You're already providing telehealth in your practice, or this doesn't apply to you because you're not in a direct patient care setting or you're not in an outpatient setting, perhaps. Although I will say that a lot of our inpatient practitioners are also providing telehealth inside hospitals and health systems. So definitely could apply for inpatient providers. So we'll leave this poll up for a while and see here where we're at. Okay, let's get the results. So it says that about 35% of you are not currently providing services but are interested in starting, and about 26% of you are already providing telehealth services at some level in your practice. A small number of you are not planning to provide service, and some of you, about a third, have said that it doesn't apply to your practice. Well, thanks for responding to that. I want to take a question from Mark Gilliam. Mark, we're going to unmute your line and let you ask your question. Mark practices in a rural independent community pharmacy, and with some of the easing of restrictions, they've been looking into telehealth. He thinks that establishing a relationship with a local provider and providing remote patient monitoring is the easiest to work into current workflow processes, especially using the e-care plan standards. Have any of you seen telehealth successfully implemented in a community pharmacy, and is direct supervision by the provider required for remote patient monitoring? Great question, Mark. Great question. Any of our panelists want to answer that question? Okay, Nikki, go ahead.
So in our network of community pharmacies, and we have about 15,000 affiliated community pharmacies across the country, we definitely have pharmacists that are doing remote patient monitoring, that are doing chronic care management, and have implemented collaborative practice agreements like you're talking about with local practices and providers. In order to provide chronic care management or remote patient monitoring, there does need to be a relationship with a provider or provider practice in order to be providing those services. So that's definitely a requirement. There are also more broad collaborative practice agreements that cover other types of services. So it might be at the state level where there's a collaborative practice agreement that, for example, allows immunization or broader kinds of things.
All right, great. Yeah, so we received some comments in our questions box, just some comments from other pharmacists on the call who are providing telehealth services, and they also have validated that yes, there needs to be a physician relationship and oversight there. So I appreciate that feedback from our audience as well. We have one question that's come in that's not about telehealth. It's a clinical question, and I'm going to ask the question to Dan Zlot. Dan, there's been a little bit of discussion lately about ivermectin, and that's not something we've discussed on this call. We've discussed an awful lot about other drugs for the treatment of COVID. Is there anything we should know about ivermectin? Is it working, or is it a valid treatment for COVID at this point?
Michael, that's a great question, one we've received as well a number of times. So there's quite a bit of information about ivermectin and some drama, so I'll try to condense it as much as I can. So just some background about the COVID-19 virus. One of the things that we think it does as it infects cells is that it inhibits the body's ability to signal that there's a viral infection of that cell, and that prevents our bodies from mounting a strong response against that infected cell. So the way that ivermectin is proposed to work is that it inhibits the inhibition, thereby allowing a more normal immune response or a more normal cellular antiviral response. So that's the proposed mechanism of action. There are in vitro data only that suggests that ivermectin is very effective at inhibiting the viral replication of the COVID-19 virus. That being said, that's in vitro only, and one of the things that hopefully we've all learned from the COVID-19 experience, if not other research, is that humans are not cells in petri dishes, and that the fact that you can treat the COVID-19 virus effectively in a petri dish does not necessarily equal the same results in humans. And so there is very little and almost no clinical data, even case reports are extremely sparse, suggesting that there's any benefit in humans to ivermectin at this point. And I will add that there was so much attention to this, particularly because ivermectin is widely available as a veterinary medicine, that the FDA felt there was so much attention around ivermectin that they actually issued a warning letter on May 1st to let people know that ivermectin has not been tested in humans, and also humans should not take veterinary formulations of ivermectin. So that's sort of all the drama and the information squeezed into hopefully less than 2 minutes.
Well, that's great. You know, even though I'm a pharmacist, I remember ivermectin growing up on the farm, and we used to give ivermectin to both our chickens and our cows, but I've never seen it in a human, so I guess it's a different thing. So thanks for bringing it up, and appreciate that question. It was a great one. I want to thank Kathy, Taylor, and Nikki for joining us today. We are going to transition to some other information, so thank you all for your wonderful wisdom. I want to now ask the three of them to deactivate their webcams, and I'm going to ask Mitch Rotholz to join me to share some updated guidance from CDC on vaccination. Mitch?
Okay, thank you, Michael. So we've got one slide that I'll run through real quickly. On June the 9th, CDC released its revised vaccination guidance. We broadly disseminated it. The link is on the slide. The two guidances that we encourage pharmacists to pay attention to are this updated guidance on vaccination as well as the guidance for pharmacies. Those two together should give you a good sense of the approach that CDC is recommending for pharmacy providers to utilize. Key to the new recommendation is that they took out the word postpone and encouraging providers to assess vaccination status and vaccinate. So vaccinate where you, the practitioner, are comfortable, as well as the patient is comfortable in getting the vaccine, utilizing that discussion between the pharmacist and the patient. In addition, what's unique that in this update is that you should be screening for fever, that means taking temperature, and screening for COVID symptoms. Also, if somebody has a fever or symptoms, you should postpone or delay vaccinating them until they are able to not be in isolation. Additionally, from the masking perspective, patients coming into your pharmacy should be wearing a cloth mask, and you and your team, the healthcare providers, need to be wearing medical face masks. Also, eye protection, depending upon what's going on in your community, what the guidance is in your community, is encouraged. And if you're going to wear gloves, make sure that you change your glove between patients and wash your hands. And then lastly, when we're coming into the flu season, is that really pay attention to targeting certain patients, especially. Those are our essential health workers, that includes your pharmacy staff, persons at risk for developing severe illness from COVID, and then persons at high risk, like any other flu season, for getting complications if they contracted influenza. That's a quick synopsis of the guidance. It has more detail in there, but if you have questions, please send them through on the Engage platform.
Great, Mitch, thank you. And Elisa Bernstein, I think you're going to share some information with us too.
Yeah, so I wanted to share with you, again, we share with you every week. We have APHA's 15 on COVID-19, short little 15-minute CE, and we have some new ones that came out. Hydroxychloroquine, the saga continues, and remdesivir. So as usual, click on the information there and you can go to these, and this is 20, there's 20 of them, and we plan on continuing more, so keep checking back. Then other thing that I wanted to tell you about in the next slide is that APHA has our resources, our practice resources that we continue to develop. And we just released one on telehealth, which is extremely appropriate based on the topic today. So if you want to hear more and read more, a little bit more concisely, and to complement some of the great presentations that we heard today, go to this website, and it has our telehealth resource, as well as, I think we're up to about 20 now. And we continue also to provide these types of really short, to the point resources for you to know about COVID and your practice. We also, in terms of what's happening on the regulatory side, just in our short little update, what happened in the last week that could impact you, as if you're a regular attendee of our sessions, you know that we've talked about pharmacist testing a lot, giving you updates on the regulatory and legislative updates there, as well as implementing and testing. Just this week, HHS released a guidance that specifies the information and demographic data that must be reported by labs. And a pharmacy that offers point-of-care testing is a lab. So this is information that will need to be reported. HHS is stating that this is going to help them monitor disease incidents, trends, help with contract tracing, that's a mouthful, assess availability of testing resources, and really look at supply chain issues as well. So if you are going to be starting to do testing, or if you are testing, this is something to keep in mind. This is a lot of information that you'll need to provide, but it's information that you'll have to collect in order to be able to provide that as well. As we've mentioned every week, we are working on to get more authority for pharmacists to do testing and immunization for COVID-19 and flu. You can take action by going to the APHA Resource Center, and very easily you can go there, and with a couple of clicks of the button, you can send letters to your legislators. So go to our action center at this website in order to tell Congress to help let pharmacists have more authority to help fight COVID.
Yeah, Lisa, thank you. And before you go, I do have one quick question for you. You mentioned on the COVID testing that pharmacists would need to report all of those data points. To whom is that reporting done? Is it done to a state agency like the public health department, so are states collecting that, or is that done directly to HHS? Where is that reporting submitted?
So that's all evolving. The guidance will say that. So we'll have more to say about that.
Okay, great. So evolving. Well, thank you for that. I want to encourage our attendees to plug in to APHA's Engage platform. This is an opportunity for all of you who are providing care, all of us are, during the COVID response, to talk with each other, share ideas, and support each other, as well as access the latest information on COVID-19. We always, each week, take questions that we weren't able to get to in the webinar and try to answer some of those questions on the Engage platform. So we encourage you to fully engage with Engage as members of APHA so that you can learn more about this topic. Now, next week, we're going to be doing something a little bit different. As many of you know, the APHA annual meeting in a face-to-face version didn't happen this year, but APHA 2020 Virtual was launched and is available for you to register for now and receive quite a number of CE opportunities through APHA 2020 Virtual. We recognized and had planned a virtual webinar on legislation and regulations affecting your practice, and we realized that that's a critical topic for us now during COVID, a very critical topic. So we've decided that next week we're going to merge together APHA 2020 Virtual and our weekly COVID-19 webinar. And we're going to devote 2 hours to the session instead of 1 hour. And here's the best thing for all of you. If you register for next week's webinar, you will receive continuing education credit, 2 hours for attending next week's webinar. Here's the catch, as it's shown on the next slide. We will be starting the webinar 1 hour earlier next week only. So it'll be a 2-hour webinar that starts 1 hour earlier than our normal start time. So I encourage all of you to join next week, to let your friends know about this webinar. It will be rich with information about legislative and regulatory changes that have happened to move us forward with COVID-19. Well, thank you all for joining us. We've reached the end of our hour together. We appreciate your dedication to your communities and to the patients that you serve. We're proud of you, pharmacists, student pharmacists, and pharmacy technicians, for the difference that you're making in the lives of patients each and every day. Thanks everyone for joining us. Have a great day and God bless.